Right.
Hello, good evening, everyone. Welcome to the Facebook Live at Global Hospitals Parel, Mumbai. Today we have with us Dr. Pravin Kulkarni. He is the Senior Consultant, CVTS, and Lead Heart Transplant at Global Hospital, Mumbai. After completing his MCH from PGI, Chandigarh, he worked with St. Vincent Hospital, Melbourne. The hospital are the pioneers in surgery for aortic dissection and aortic root aneurysm. He then worked as a fellow at Toronto General Hospital in Toronto, which is again a center of excellence for aortic surgery, heart transplant, temporary and destination wards. As consultant cardiac surgeon, Dr. Kulkarni was a very active member of the heart transplant team at Fortis Hospital, Mulund. Post that, he worked with Sir H.N. Reliance Foundation Hospital before joining Global Hospital. His expertise includes arterial grafting in CABG, off pump, on pump, simple to complex valve surgeries, mechanical circulatory supports, destination wards, and heart transplant, to mention a few. I welcome you, Doctor, on the show. Thank you so much for being with us today.
Thanks, Jyoti, for your kind words. Thanks a lot.
So, today's topic, Doc, as we spoke about, is what is a heart failure? We hear the word heart failure. We have heard many, near and dear ones facing this issue. So my first question to you is, how do you define heart failure?
Yeah, so heart failure, first of all, thanks for selecting this topic because we really need to create a lot of awareness in the society with regards to heart failure. Now, heart failure, if you have to define in scientific terms, I would say it's a complex clinical syndrome in which heart is not able to meet the metabolic demands of the body. In common man's language, I would say heart is not able to meet the demands of the body. Now, if I have to quote you with an example, I would say like every day in the morning, I try to take stairs to the hospital. Like first five stairs, I'm absolutely okay. I feel like I'm doing good. But the moment I cross the five stairs, like five flight of stairs, and I'm climbing the sixth and seventh, I feel short of breath. I feel I'm tired. So that feeling, like that feeling of tiredness when you're climbing stairs is these heart failure patients experience when they're doing it in the first two flight of stairs. When it's very unpleasing, like if I have to climb just one or two flight of stairs and I start panting and I start feeling breathless or start feeling fatigued. So that is how a heart failure patient feels. Or if I have to give you another example, like you must be driving a bike, probably a bike like Activa or a moped or something. So first day when you buy a bike like this, it goes zoom, zoom, zoom. You can just take it anywhere you like. But the same bike, if you're riding 5 years or 7 years down the lane, especially when you're driving up slope, you just accelerate and the vehicle doesn't want to go. And that time, if say someone sitting behind you, just ask that person to get down. Like the vehicle is not going up slope. I need to take this vehicle up. So this is a heart failure. Basically, heart's like an engine to the vehicle. A vehicle is like the body. And when you take this vehicle to a mechanic, the mechanic says that there is some problem. Block piston mein kharabi hai. So that block piston either needs a repair or replacement, and that is what the topic of discussion today. Like this heart, which is technically not doing good, which is the engine of our body, it kind of needs a repair, or if not, it needs less burden to work against, or thirdly, it probably needs a replacement. So that's how I think there needs to be an awareness for this heart, which works like a engine in our body.
Okay. Doc, what is the magnitude of this heart failure issue in India currently?
So if you see, we actually don't quite have the exact numbers because there's not a national database which maintains the heart failure patients. But as per projections, we can say like there are almost 4.7 million people, like a half a crore population. We are a country with a population of 130 crore, 135 crore patients. In like population, and in that, like almost half a crore of population at any given point suffers from heart failure. There are almost 4 to 4.7 lakh people who get added up every year to this size of population. And also, I want to say, if you see the mortality, like now there is a class of patients who are like NYH class 4. When I say NYH class 4, these are the patients who feel breathless at rest. So these patients, the chance of them surviving through 1 year is just 50%. Like so, there are a high risk population which needs care, which needs awareness, and which needs treatment.
Oh, that's a phenomenal big number of the patients. We'll talk. My next question is, what are the causes of heart failure?
Yeah, so heart, which is the engine of our body, there are many reasons why an heart can fail. So there are reasons specific to heart, or it can be reasons related to blood vessels, or it can be reasons related to lung, or other miscellaneous reasons. Like now, when I say heart, per se, like heart can have blockages in the blood vessels supplying the heart, for which it may need bypasses, or the heart can have valvular affection, like a patient can have AS or MS or MR or AR or a tricuspid regurgitation, a valvular affection of the heart. Or thirdly, the muscle, the myocardium of the heart may have some genetic problem. We call it as cardiomyopathy. There are different types of cardiomyopathies like dilated cardiomyopathies, ischemic cardiomyopathies, peripartum cardiomyopathies. Other than that, there can be rhythm related disturbances of the heart, which can itself give rise to heart failure. Secondly, there can be trouble related to the blood vessel. When the blood vessels can be stiff, which can give rise to hypertension. So, hypertension is the pressure against which the heart pumps against, and that itself can lead to heart failure. And also, there can be lung related conditions like if there is severe pH, the lung pressures go up, that can lead to right heart failure, and that could be one of the reasons why patient can get heart failure. And also there can be miscellaneous reasons like there can be anemia, there can be B12 deficiency, or there can be hypothyroidism, or there could be infectious causes like Chagas disease or viral myocarditis, which can cause myocarditis and heart failure. And also there can be lifestyle related things like excess alcohol intake, or excess salt intake or excess fluid intake, which itself can give rise to heart failure. And lack of exercise is something which is can cause more trouble in heart failure.
So you mean there are several reasons due to which a heart failure can happen. So,
Right.
Doc, there must be some signs and symptoms if a person is having a heart failure condition. So, what are they? You could just,
So,
explain.
there are two things. One is symptoms, what the patients tell us, and signs is what the doctor notices in the patient. So, if you go by symptoms, these patients usually the most common symptoms is breathless, SAS Nicola. These are the people who are conscious about every breath they take. Like if you see in normal people like you and me, we are hardly aware like when you breathe. But these are the people who are aware about every breath what they take. So they do complain of breathlessness, and they are not able to lie flat. Like when we sleep in the night, we lie flat. But if you see these kind of people, they usually want to sleep with propped up, back a little up than normal. They would take like do takiya liya, teen takiya liya. And also they wake up quite frequently in the night. Like there is a air hunger. They have to they wake up, they have that air hunger, they go near the window. We call it as paroxysmal nocturnal dyspnea. Other than that, they have swelling on the feet. They feel less hungry. The appetite goes down, and this is what they complain. And similarly, when such a heart failure patient actually walks into a heart failure clinic, what a doctor notices for us is like there can be some fluid in the lungs, which can give rise to Krebs. There can be fluid in the abdomen, giving rise to ascites. Also, they can have pedal edema. If you auscultate, the LV apex can be up, way displaced. There can be an S3 gallop. If you see for the JVP is raised. And if you press on the liver, there's something called as hepatojugular reflex. Like you press on the liver, the JVP goes up. So these signs can be seen positive in people who come up with heart failure. So it's more of a clinical problem, like wherein patient gives complaints and history about him being in trouble. And when he comes into a clinic, we get to see these findings in such patients.
So, Doc, when you see such signs in these patients, there must be a process of evaluating them, right? So, how do we evaluate the heart failure condition or the heart failure patients?
So with a very high index of suspicion that the heart's not doing well, we need to evaluate and further know what exactly is happening. Like so, routine blood tests like NT-proBNP. Now, in some overseas countries, like if the NT-proBNP is way high, like if it's about 2000, they just give it to a heart failure clinic to handle and look into what are the causes for heart failure. And other than that, the routine tests like an ECG itself can show like there are ST elevations, there are T wave inversions. Sometimes they can be Q wave suggestive of old infarct, or they can be broad QRS complexes. And so an ECG itself can be an indirect suggestion that there can be a heart trouble inside. Like, and most common thing what is being used for evaluation, and the most easiest thing rather I would say, is a 2D echo. 2D echo is basically just a sonography of heart, but it can give heaps of information. Like it can tell if the heart has got any regional wall motion abnormalities, if there are any valvular affections, predominantly if there's an AS, AR, MS, MR, or a tricuspid regurgitation, which is commonly seen in such patients. Also, it can tell you about how the LV is doing, how the LV function is, how the RV function is, and also how are the indirect estimate of how the lung pressures are doing, how the PA pressures are doing, and the IVC, whether it is collapsing, not collapsing, whether it is dilated. So all this information we can get in plenty in an easy way when we do a 2D echocardiography. Next in
Okay.
line is probably a coronary angiography that can tell us whether if there are any blockages in the blood vessels supplying the heart, and if there is any index of suspicion, like especially when we are evaluating a patient like this, we can actually subject these patients to MRI of the heart. MRI is very useful because it tells us about how much of the scar burden is there in the heart. When I say scar burden, basically how much of the muscle in myocardium is live and how much is dead. Something which is dead usually never recovers, but something which is live and hibernating, we can help by revascularizing the heart. So, to know the scar burden, MRI is a very important tool. And having done the MRI, and if such patients are deemed suitable, like okay, the heart's no good and he needs to go in for a heart some procedure like a heart transplant or something like that, we need to know how much is the PA pressure. PA pressure is basically the pressure in the pulmonary arteries and the pulmonary vascular resistance. This is important because if such a patient needs a heart transplant, the new heart is a healthy young heart. It's not used to this high kind of PA pressure. So a right heart cath before a heart transplant is quite mandatory. It tells us about the pressure in like right atrium, right ventricle, the PA pressures, the LVDP, and the left atrial pressures. Other than that, another thing what we can do to assess would be is myocardial biopsy. Like in cases like viral myocarditis and all, like we can do a myocardial biopsy. There's a catheter which goes into the IJV and picks up small samples, and these samples, when sent for histopath, they do tell us like what how exactly is the tissue doing inside. Like
Okay. So these tests will actually help us evaluate the condition of the patient. Right,
right,
doctor? Okay.
right.
Doctor, like when we hear any other diseases, they generally have different types in all the diseases. So does even heart failure have different types, or it's just like one heart failure?
Right. So God has given us one heart, but there are two sides to it. There's a right side and there's a left side. And also, very commonly, you will hear some terms like heart failure with reduced ejection fraction. Now, this concept is quite easy to understand because the pumping power is down, so there's a heart failure symptoms. But there's something called as heart failure with preserved ejection fraction. So these are the patient in which the muscle is hypertrophied and there are increased LV filling pressures. And despite the EF being good, still these patients present with heart failure symptoms. So this is called as heart failure with preserved ejection fraction. To elaborate further, like patients with EF less than 40, they are the ones with reduced EF, and patients with EF above 50, they are the ones with preserved EF. And there is a range between 40 and 50, which is called as heart failure with mid-range EF. So that's how they classify it. There's another way of looking at it and speaking about it is like there's a systolic heart failure and there's a diastolic heart failure. Or further on, there's a left side heart failure and there's a right side heart failure. Like sometimes when the LV goes down, the left atrial pressures go up, left atrial pressure goes up. There's pulmonary edema, and these are the patients who have symptoms to breathlessness, cough, orthopnea. And sometimes when the PA pressures on the right side starts failing as well, and you have symptoms related to right heart failure like pedal edema, loss of appetite, and increased JVP. So, and as well, there is something called as biventricular failure, in which there are the both components of heart failure are present. Like there's a left heart failure which is there, and also there's a right heart failure. Like there's a both components to the heart failure. And the next question was stages, right? Yeah, nice to bring up this question. Yeah. So if you see the stages of heart failure, it is the AHA classifies into A, B, C, D. So A is basically people who are at high risk but they don't have any symptoms. B is someone who has structural heart disease in the heart but doesn't quite have symptoms from that. C is like patient has got a structural heart disease and there are symptoms relating, or probably it's the beginning of symptoms from that. And stage D is wherein there are refractory symptoms, like despite everything, like there are refractory symptoms. That is one way of looking at it. Second is there's an NYHA classification, like 1, 2, 3, 4. In short, I would say one people are the ones who are doing okay. Four Stage four is basically somebody who feels breathless when he is at rest. So once we say a patient is into advanced heart failure, there is a further classification which grades into 7 levels. So if you start from level 7, 7 is the one person who is kind of placeholding, who's doing okay. Then comes the level 6. 6 is like he's walking wounded. Like when he tries to do some activity, he gets wounded, he gets in trouble. Then comes to 5. 5 is like he's homebound. Because he knows that he gets in trouble, he doesn't like to step out of home, but he doesn't complain. Then comes the stage 4. Stage 4 is frequent flyers. Like they keep going, they keep repeatedly getting admitted in the hospital, get some lashes, get some treatment, and then come back home. Like so, stage 4 is frequent flyers. And stage 3 is they need to get admitted in ICU and they need some inotropes, but they eventually get better with lasix and some diuretics and some inotropes. Stage 2 is basically when despite inotropes, despite diuretics, they keep sliding on the inotropes. And stage 1, which is the basically it's a cardiogenic shock. These are the ones like crash and burn. Like these are the ones who are in deep trouble, who need temporary mechanical circulatory support for stabilization.
Okay. So even this has quite a lot of stages. So
Right,
doctor, when there are stages, when there are types, there must be also the line of treatment today that, the world has
right,
invented.
right,
So
right,
what are the different line of treatments, preventive, therapeutic, that is used in heart failure disorder?
right. So this whole idea of staging and knowing what the stage is, basically we need the timing of treatment is very important. It's not just what armaments you have in your, like what arms you have in your armamentarium, but it's also about at what stage you offer a particular arm. Like so, if somebody has a structural problem, like somebody on angiography has got a coronary artery disease, the easiest thing to fix would be is doing a bypass or a percutaneous angioplasty. So, if the myocardium is viable or hibernating, like with revascularization, the myocardium behaves better, the pumping power of the heart is improved, and the heart is optimized to best what it can. Also, if some people they have valvular affections, like if there's a severe AS or there is a severe MS or MR or a TR, like if you do a valvular correction with a surgical procedure, heart tends to function better than what it was before. Some patients they are very high risk, like they are so sick and so much in cardiogenic shock. So at times, interventional people these days have come up with procedures like TAVR, in which an open operation is not done, and you can actually fix AS and actually give a more competent valve and avoid an operation and make the heart work better. And also some people they got this LV aneurysms which can be fixed and which help because again the heart doesn't contract properly, and also there's a chance that they can gather clot and embolize and give rise to strokes. So other than these three things, so whatever needs to be corrected surgically to the heart to make it better, we should do it. There's nothing like a God-given heart. So whatever heart we have, or however bad it is, like there's nothing better than the God-given heart. Like so, we need to try and make it good as much as possible by surgeries or procedures or by giving medicines.
So doctor, then the heart failure patients, and in some of the heart failure patients
Let me finish up before. Sorry to interrupt. So I just finished the surgical aspect of it. Secondly, is like despite that, if the heart's weak, so there are few precautions or few lifestyle changes. As you asked me about preventive things, so few lifestyle changes which are very important to ensure that the whole idea is basically to stay away from hospital and doctors as much as we can. If you have decided not to go for very advanced therapies, if you have to preserve with our own native heart, there's some preventions, some precautions what we need to take, like a simplest advice like not drinking more than 1.5 liters in a day. It can be a very big advice because this is the volume inside the body which actually the heart is pumping against. Secondly is like you need to give up on all your vices like smoking or probably alcohol. You need to stay away from it. Then also an advice like in Indian diet, what we go wrong is basically we are used to eating a lot of salty diet, like like we like pickles, we like papads, but all these things in heart failure patients they are not good. Also, you need to stay away from snack food, anything that is in the packet. Trust me, if you just read the label behind, there's heaps and heaps of salt in it. Like, so the advice as per guidelines is like the salt intake should not be more than 2 grams. Like, and in a conventional diet, like what we take, rotis and sabjis, I think there's enough salt. So we not take any additional salt and stay away from salt, which itself can prevent us from a lot of trouble. And if we are to accept that my heart's weak and I need to be optimized medical, so we have our cardiologists who usually have a few drugs. Like simplest of is like a diuretic to offload the excess fluid on the bone. Second is like an ACE inhibitor. The heart usually pumps against a blood pressure. So this ACE inhibitor, then there's a drug which is very popular, Vibana, and like it's a ARNI kind of drug. It basically helps to reduce the afterload so that heart pumps well and good, and there's afterload reduction by giving ARNI kind of drugs. Thirdly is like there are beta blockers who control the blood pressure and also they control the heart rate. And then next we have the ivabradine, like it works against the funny current. For that, patient needs to be in sinus rhythm, but it only helps in the rate control. It doesn't cause any drop in pressure. So if you just want some rate control, then ivabradine is very useful. And other than that, there are nitrates and hydrolysine, which can decrease the afterload or decrease the preload. And sometimes even a drug like digoxin helps if you need to keep them in sinus rhythm. And so these things, having done like with the structural procedures, having done with these medicines, having taken the preventive measures, there's another thing what can be done in such patients. Like these patients, they are at risk of sudden cardiac death. So to prevent this risk of sudden cardiac death, or sometimes they have broad QRS, and if you pace the right and left ventricle in the correct rhythm, their heart functions better. And if to prevent the sudden cardiac death risk, these patients kind of need a defibrillator. Like, so an ASCD and sometimes a CRTDD, in which there is a synchronous rhythmic pacing of the heart, and also if there is a weighty kind of thing, a defibrillator acts in to prevent the risk of sudden cardiac death. So despite all these things, only this is all one side of medical treatment. We call it as optical medical therapy. That is maximum. Try and do as much as you can do to preserve the God-given heart. But despite that, if you are failing, at times, if someone is 70 years, he just says like, okay, I'm done. I don't think I need to do anything further. This is a call which is a very holistic call, which I feel is not the most wrong thing to do. But if someone is like 25, 30, young, dilated cardiomyopathy, who's in heart failure, and if he makes a decision like that, I think that's not fair. The reason being is like we have this heart transplant option, which is a safe option. In year 2010 and before, probably such an option never existed. But in year 2021, when especially when we are in the 21st century, and heart transplant is an option, it's a safe option. So, yeah,
So when you say heart transplant, that means we having a new heart in the body. I mean, that is
right.
as a layman what I can understand. But can you let the viewers know a little more about what heart transplant is? What is the procedure? How is it done?
Right. So, having spoken about all those things, all those measures, like procedures to preserve the God-given heart and medicines and the AICD and everything, now that we know that despite all the attempts, we are not able to do it and still we are failing. So, such patients, we subject them to something called as heart failure evaluation admission. We actually admit them for couple days, couple to 3 days, and there are a few things what we need to look at. As spoken earlier, like the easiest and best tool to screen is the 2D echocardiography. We look at how the right ventricle is, how the left ventricle is, how the PA pressures are. And once we know that this heart is no good, and still we are in doubt that maybe there's a chance that this heart may or may not recover, we need to know how much is the scar burden. Is there a live muscle what we can help to, or is it all scarred and or is it all dead? Like, so to know that, we need to know, we do an MRI of such hearts, and MRI quite helps us in telling us how much is the scar burden in such patients. And also sometimes it helps us to find out what etiology could have led to this kind of heart failure. Like, so having done these two things, the third most important thing in the evaluation admission is doing a right heart cath. A right heart cath basically tells us about pressures in different chambers of the heart, More importantly, we need to know how the lung pressures are and how much is the PVR. So a new heart is a young and good heart, like which is not used to high pressures. So we need to make sure that the PVR is less than 4 wood units to ensure that the new heart tolerates and functions good in after implanting into the recipient. So that's about the cardiac evaluation part of it. But other than that, also we need to find out how is the immunology of the patient. I mean, like how much is there a chance that this the recipient might reject the donor heart. So for which there's a screening tool called as PRA, and also these days in some patients we do HLA and SAB basically. So it kind of tells things at a molecular level, like what is the chance that the recipient patient might reject the new donor heart, and if at all there's a chance that there is increased chance of rejection in such patients. So these patients need desensitization to ensure that the new heart is not rejected. And sometimes if we still go ahead in high risk cases, that time the level of immunosuppression should be more as compared to routine patients. So that is what we look at. Other than that, in this admission, we look at how the other systems in the body are working. If infection point of view is good, if he's vaccinated good enough, and also last to mention is like if he's got a good longevity. I mean, like he does not suffering from any neoplasia or cancer. This heart should be basically it's a gift of life. It should be offered to people who need the most, who are in urgent need of it, who will benefit the most, and who will live with it the most. So this admission is basically for evaluating to find out if the old heart is really not good enough to be replaced, and if the new heart will benefit by if the recipient will benefit by the new heart. So coming down to so what exactly is heart transplant? That was your next question, I think. So heart transplant per se, when we know that this patient is suitable for heart transplant, that is the time this patient actually gets registered in ZTCC. That's a zonal government body which decides who is on the list first, who needs the most, and who will benefit the most. So based on these criteria, ZTCC does a fair allocation of organs to a person who's more suitable. Like so, one fine day, based on the blood group of the patient and based on the size of the patient, uh, when it's considered appropriate that particular recipient should get an heart, we get an alert. So one team actually goes and gets there's a first step of it is a donor retrieval. So we need to get an heart from the donor who is kind enough to donate. The family is kind enough to donate the heart. And secondly, at the recipient side, there's a recipient explant. And final step is basically donor implantation of donor heart. So right from the time the clamp is applied at the donor place to the time the clamp is released, the whole operation needs to be finished in 4 hours. So there's a race against time. Every minute is important. Every second is important. To get this heart from donor to recipient, sometimes we need to use chartered planes, and that's how the process is carried out. And other than that, if you ask me about the success rate of the operation, it depends upon the reason for which heart transplant is done. If the heart transplant is done for dilated cardiomyopathy, the success rate is quite high. Like the 1 year, 5 year, and 10 year survival rates is almost above 90%. Whereas if the same operation is done in ischemic cardiomyopathy, the results are like 85% at 1 year and probably 46% at 5 years, and again down. So the success rate also depends upon the reason for which the heart transplant is carried out. And having done the heart transplant, doing taking heart is usually connected to a body at 5 places. We usually cut at 5 places, join at 5 places. But other than the surgical procedure, there are a few things which are very important. First and foremost is like is the recipient accepting this new anything that is new, our body tends to reject it. So we kind of need to ensure that the new heart which is coming doesn't get rejected, for which we need to decrease the we need to do some kind of immunosuppression so that the new heart is accepted. So there are some drugs which need to be given during the operation, which are given as injectables. Same things are made into tablets, which later on get followed up. And there are some blood levels, like there's a drug by name tacrolimus. There's a level to it. Like so we need to keep monitoring, ensuring that it is working optimally. To ensure that there is no rejection happening, these patients need surveillance in terms of monthly echoes, monthly blood tests, and also some biopsies to ensure that there is no rejection happening. Now, the downside of this immunosuppression is like we have decreased the immunity of the patient, and there's very high chance that these people may catch infection. So we need to take preventions in terms of giving some drug prophylaxis and also making sure that they live in a cleaner environment, taking all due precautions so that they don't get infection. So this is about heart transplant. But one thing what I also wanted to tell you was when these patients are on wait list, sometimes they just slide, they decompensate. So that is a time there is something called as temporary mechanical circulatory support. So this is something which is used to stabilize the patient until the time he gets a heart transplant. But trust me, it's better to catch the patients in the right window. It's better to fix the trouble before the trouble starts. The results after putting a temporary mechanical circulatory support are not so good as compared to a compensated heart failure patient going in straight for a heart transplant. And also, if the PA pressures are up and the donor heart's not available, then there's something called as durable VATS. We call it like it's a destination therapy in which a device, the most popular device is the HeartMate 3 currently in the market. It costs almost about 85 lakhs. And that's something which is put and can be also put in like a destination therapy. Like such a patient can stay with the device, with the hardware, with the consoles, and try and lead almost as near normal life as possible. Like, yeah.
Doc, you've enlightened us so much, educated us. So before we end the show, I really want you to answer what is your message to the viewers today?
Right. I would say there are few things like I see a lot of future in this. One is I feel the awareness for heart failure. These are the people who are very much amongst us, but we are not aware that these are the people who are suffering. Number two is transplant in 21st century is a safer option. It's very much in India, and we can offer this option to people in India. Thirdly is like what we see with donations. I see majority of the donations coming from Gujarat. The community who lives in Gujarat, they have that sentiment of dan, like to do a donation and make good to someone else. So I would suggest this sentiment, if it picks up in India, it's a big way to go. We can be the epicenter of transplant surgery all across the globe. Fourthly is to ensure that the organ transplant happens in a timely way. We have these fighter planes, Rafale and Tejas, like. So if these planes in their like they need to complete some flying hours, like when it's not a wartime. So if these flying hours can be used for transport of organs, it can be a huge service to the transplant and to humanity per se. Also, these days we hear about drones and unmanned aerial vehicles. If they can be used to transport an organ for transport from the airport to the hospital, it can be a big service. And also, there are newer research happening with immunology and infection control. And if the more prosperous country, if we are living in a more cleaner environment, I guess the results of transplants would be very nice in our country.
Okay. Thank you, Doctor. Thank you for being with us in today's Facebook Live. I think in the end of this conversation, we all viewers should pick up one message that yes, organ donation is one of the biggest gift
Right.
that can be given to the mankind. So in
Right.
case there is a brain dead person or anything where a doctor tells you that nothing can happen further with this person or his life, I think organ
Right.
donation can be
When
a
there are
very
road
big
traffic
gift.
accidents, when there are intracranial bleeds, there are some stages in which ICU doctor walks up to you and tells like, "Oh, the patient's brain dead. There's nothing much we can offer more." That's the time the relatives consent for do not resist it. So that's the time I think each one of us, like if we come across such a situation, before we leave this world, it's time we can help someone else live better, especially when we know that it's not going to be of any use to us.
So let's add more to the life and believe that if we can donate the organ of a person who is not going to live further, that can be one of the best decision a family can take because there can be many lives that can be saved.
Right.
Thank you so much, Doctor. Thank you for being with us. Thank you, viewers, for being with us in this show. Next week, same time, we will meet you with a new topic that connects with health. Thank you.
Right. Thank you. Thanks.